Copyright 2009 University of South Australia. This recording may contain third-party copyright material. Apart from any use permitted under the Copyright Act 1968, no part of this recording may be reproduced or rebroadcast by any means or process without the prior written permission of the University of South Australia and the copyright owners.
Geoff, I'd like to thank you for coming in today to talk about aspects of your concept of manipulative therapy.
My pleasure.
If I may, I'd like to start by reading a quote that I've taken from your chapter, The Maitland Concept, in the book Physical Therapy for the Low Back, published by Churchill Livingston. It reads, "The Maitland Concept requires open-mindedness, mental agility, and mental discipline, linked with a logical and methodical process of assessing cause and effect. The central theme demands a positive personal commitment or empathy to understand what the person, that is patient, is enduring." I'd like to use that quote and ask you just to elaborate on the different components of it to give us a bit more insight into your concept. And if I take the first component, that is, the Maitland Concept requires open-mindedness, mental agility, and mental discipline. Can you explain that a bit further?
You probably have to ask me each of them individually. The first one was open-mindedness, is that right? Well, so many people, to me, seem to have a set plan or idea or concept of what a group of symptoms and signs mean, and it has a diagnostic title. And I tend to call a person who works in that sort of way that they're tin can trained. And it's sealed top, bottom and all the way around. And they just can't think outside that little category. I've always admired Syriax's book, his volume 1, the thick one, when he can so clearly put things into nice, very neat compartments. My only problem has been is that I find that they don't fit into neat compartments, and they're not black or white, but they're nearly all grey. So I think that one needs to have your black and white learning basis, but when you apply it in treatment and when you examine patients and find certain things, you find that they don't necessarily fit to any one diagnosis, if you like. And I feel that one's mind has to be wide open. You can't be shut in by anything, and this comes into the thing that I talk about, and which I really feel is probably the basis of the whole concept, and that is the way one thinks.
Right.
And under this open-mindedness is that when you examine a patient or when you just listen to their story, that you believe them, you take it all in, and the questions that you ask, the answers that you get and the way you interpret them are not limited by your knowledge, because our knowledge isn't always accurate anyway. So that if your mind is open, then all of these factors still are part of your thinking, so that you can vary what you do depending on what you see and what you hear, and that you're not compelled to think in a particular way. That's sort of
right. Well, that is the agility also, yes, of your thinking.
That's right.
And I imagine it's that sort of thinking that's allowed you to come up with some of the techniques that have come out of your concept.
It's the only way that they can come up. If you haven't got that open-mindedness and mental agility, being able to dart from one thought to another thought.
Could you elaborate just a little bit on any one of those, such as the slump, which I think is something you spoke about, how that came about?
It's interesting, and one of the things which I'm very, very pleased about is that having started off, and I'll tell you how it started off, has developed so much by so many different people that in another 10 years' time, that's going to be such an enormously valuable part of our equipment and our knowledge and understanding. And I'm thrilled to see other people sort of taking over, because you can't do everything yourself. The way it came about was I believed what Dr. Syriacs has said, written, in relation to dural pain. I've never felt happy that it's limited to dura, but it should be limited, I would think, to pain-sensitive structures in the vertebral canal. And the only test that Dr. Syriacs uses for his dural pain is with a patient lying supine doing passive neck flexion. And to me that hasn't been adequate, because there have been a lot of people that I have felt, I've had reasons for thinking, but I don't know what they were, but I felt that this was canal or dural, but there were no positive tests that you can say, well, here, it must be. Until, I don't know how many times I heard it, but a few patients would say that patients who had low back pain had difficulty getting into a car. Now, as far as the mental agility and the being critical of self, that answer isn't enough. And as far as I'm concerned, if you think that it is enough, then you aren't working within the concept as I see it. Anyway, I would say to this person, why can't you get in the car? I mean, what is this difficulty that you have? You tell me in your words. And I can well remember one person saying, well, I'm all right, I can open the car door and I can sit in sideways and get down there, and I can get one foot in, perhaps get both foot in, but I can't get my head down. Why can't you get your head down? Because it hurts in my back, of course. So I thought, okay, when you lie that patient down supine and do neck flexion, only neck flexion, you can do that strongly and you don't provoke any pain at all. But if you simulate they're getting into the car, and this is what I first did with the first person, I got him to bring his car around to the rooms and show me what his difficulty was. And when he said, well, no, I can't get in any further than that, then I grabbed hold of his head and put his head down, and he jerked with pain in his back. So I thought, all right, so we'll sit you on the side of a couch, we'll get you into full thoracic and lumbar flexion, and bend your head down from there. And if it didn't hurt them in that position, then I got them to, because I was thinking of dural things, I got them to do double straight leg raising, as it would finish up, because they're sort of out in that position,
right.
and then at it. And it always provokes their back pain, and you can relieve the back pain by releasing their neck flexion.
So that's really a technique that's actually evolved. I mean, your comment that other people have taken it and are going further with it, it's not something that's been developed and then kept as is.
Oh no,
It's changing.
I do things differently now than I did 30 years ago.
Yeah.
But one of the things that interested me recently was looking back at the first edition, which is published in 1964, that those same principles are still the basis of what I do, even though the book is 4 times thicker and everything else. It's just an expansion of those same basic principles.
That's excellent. If I go on to the second component of that quote, where that open-mindedness and mental agility and mental discipline that we just discussed is linked with the logical and methodical process of assessing cause and effect. Can you elaborate on that assessing cause and effect and how that is important to the concept?
I'll try, but if I don't answer what you're thinking of, then please ask me. The mental agility means that you have to be able to adjust any technique that you're going to use to the patient's disorder and how it affects them physically. The mental discipline is that you make a supposition in your own mind on what you find with the examination, and you do a specific technique for a specific reason. And it doesn't matter whether it's the right or wrong technique, and it doesn't matter whether it's the right or wrong reason, but you do it for a specific reason. It may be that you want to provoke the person's symptoms or reproduce a part of their symptoms, and you do it, you know what you're doing, you know what the person's feeling while you are doing it, and then afterwards you sit them up or stand them up, whatever it is for, and you say, well now, just wriggle your neck around and loosen things off, this is if you've been treating their neck, and say, well now, how do you feel now compared with before I did that with you lying down? And the speed with which they can answer is valuable in itself. If they have to sort of hesitate and think, well, I think it's a bit better. Well, then you know that it isn't much better.
Right.
But if there's been any change, it's been favourable. But you've got to be critical with yourself all the time. You don't say, does that feel better now? If you want them to say, yes, it is better, then you say to them, is that any worse? Because they're far more, or their answer saying, oh no, it's better. That's far more informative than if you say, now how is it like? What's it like now? And they say, oh, it's better. But the other way, it's much more positive. That's the sort of mental discipline. And then you have to make use of that information to tell you whether you're going to change a technique, or whether you're going to do the same technique but stronger, or whether you're going to do the same technique but more gently, or the opposite technique. Is that the kind of
And
thing
that's your cause and effect. That's when you're going back and actually testing what you were thinking.
Yes, and when you are assessing the effect, there are often different components of your examination findings. I'm thinking of the testing of movements, etc. I think that there can be a difference between changes in their sagittal movements without making any difference to their coronal movements, or spinal movements as compared with movements of the pain-sensitive structures in the vertebral canal. And when you do a particular technique and you are going to want to know what its effect is, you've got to look at each of those components, because it may affect one and not the others. And therefore you know that the person's got two problems.
That's excellent. I might just go on to the third component of that quote, which reads, the central theme demands a positive personal commitment or empathy to understand what the person, that is patient, is enduring. This personal commitment, what can you tell us more about that?
Well, I think that if you haven't got that, then you shouldn't be treating patients. That's number one. I think that probably 95% or 99% of people who think that they have got it, in fact, either haven't got it or haven't got it enough. I think that one, as a clinician, examining and treating a person who happens to be a patient, but he's a person or she's a person, that you've got to feel for them. And I feel that it's terribly important, particularly on a first consultation, to establish good rapport between yourself and the person. And I don't mean just good communication, but that they have to feel happy with you and confident with you, and to be prepared to say what they might feel are silly things. In other words, I think we've got to tell them, you can't tell me too much, you can tell me too little. What you don't tell me, I don't know. Your body can tell you things, and if you don't tell me, then I don't know anything about it. Nothing is too trivial. It's far easier to treat the person who goes on and on and on like the babbling brook, because you can cut them off. If you're skillful enough, you can cut them off without it being rude, and just pick the meat out of what they're saying. But the person who is reticent to talk, they're just so much hard work. And if you can pick that in a person, I think you want to tell them straight away, you are going to be partly responsible as to whether we can make you better or whether we don't.
Yeah.
So I feel that you've got to get inside the person, you've got to try to feel the same sort of frame of reference of their genetics and their environmental things that have happened, so that you can feel for them. And then you've got to know what their symptoms are and how they affect them as a person, so that you can live their life for them, almost.
Well, do you have any particular ways or tactics that you attempt to communicate that empathy? Or is it always different with every patient?
Well, it's individual. If somebody comes in and they're arrogant people and they're anti coming in for treatment anyway, they're only coming because the surgeon has insisted that they must come, then you've got a lot to overcome. And I think that it's not only the words that you use in asking them questions. I'm thinking of the subjective part rather than the objective, because the objective is so much more straightforward, even though I think it's got pitfalls that people don't really see. If I can just diverge for a second, I'm thinking of a man that I saw only 3 or 4 days ago, who had been to an orthopaedic surgeon, a man whom I know and whom I respect quite well and have treated patients for him for years. And this patient only had right-sided back pain, but it was bad enough at times to prevent him from working. This orthopaedic surgeon had examined him and couldn't find anything wrong. And the surgeon examined the man's straight leg raising by saying to him, he was lying on his back, lift your left leg up, lift your right leg up.
Yeah.
When I did the straight leg raising and I did it passively, there was a marked difference between the sort of feel-through range. And the very interesting part was that, in fact, the straight leg raising on the contralateral side was the one that provoked pain on the other side. So, to me, having done that, even though I hadn't done anything else, that would give me one very good reason for thinking this back problem is going to be hard to help.
Right.
Whereas if it was an ipsilateral, it would have been much easier. Sorry, I have diverged. What was I talking about?
No, that was
techniques of
tactics or techniques of trying to communicate that.
Well,
rapport.
I think there are two things that we can use. I mean, other than your questioning, I think you want to use their language. You don't want to use technical language and talk about a limitation of lateral flexion between C2 and C3. The patient doesn't care about that. He talks about here and he can't tip his head over that side. So I think you've got to use their language. And I think the second thing, or the two other things that are most valuable, one is that as well as speaking in the sort of tones and words that the person uses, I think that you have to make a lot of use of the non-verbal communication. And like I did then, the non-verbal, up go the eyebrows, and the odd smile or tip of the head when they say something. And I think that is more valuable even than the words that you use.
And that would go both ways. You're picking up on theirs.
Yes, I'm picking up theirs, but I don't think that we as clinicians use our own non-verbal equipment in the way that we can. It's one of the reasons why I will frequently get the patient to sit up on the couch while I kneel down alongside the couch, so that they're not looking up to God, they're looking down to me, and so therefore they have or don't have the feeling of being inferior. The other thing I think that is enormously valuable is touch.
Right.
But I think you've got to be very careful who you use that on. I mean, lots of people don't like touch.
Yeah.
So I just wait and see, and if the person in talking to me sort of does things like this, and you know, well then I can feel quite sure that I can say, well, I think we might be able to help you, but you'll have to help me. And then they feel a sort of closeness with you.
It's really instilling confidence.
That's
as
right.
well, isn't it?
That's the whole thing.
That's excellent. I know that's just touching on some of the aspects of the concept, and there's more detail in that chapter, and as well as in your latest edition of vertebral manipulation. But I do appreciate you coming in today and just elaborating on that for us.
Good.
Thank you.
Thanks a lot, Mark. Mr. Gorwin, I presume.
Yes.
Geoff Maitland. How are you?
Good.
What are you here for?
It's my neck.
No, you need to answer that one. As far as you're concerned, what do you feel at this stage is your main problem?
You mean now?
Why are you here? In your terms.
It's just that my neck hurts.
Whereabouts?
It's just here. Just about there.
Are you pointing with all your fingers or just one of them?
Oh, sorry, no, just there.
And that's the only place that you get any symptoms at all?
No, I get it down here too. But only when that's bad.
So that has to be bad for this to come on.
That's right.
And this part that you get here, is that constant or is it intermittent?
No, it just comes and goes.
And what about this?
Oh, that's very rarely there. If this gets really bad, well then that comes on.
And does this join up with that?
No, don't know. Happened yesterday, and no, I don't think there was a jet. No, it didn't join up.
A key word in terms of communication. What happened yesterday? Why did you use the word yesterday? What was it?
I was doing a lot more typing yesterday than I normally do.
I see.
And that brought it on.
Good. Having done all of those movements and poking around in your neck, how does your neck feel, your problem part feel now in comparison with before I started doing anything?
It's just the same.
Good. Can you just tip your head backwards? Anything?
No.
Go on, back you come. Back you come. A bit more. A bit more. Anything yet?
No. Oh, that's a bit sore.
Where?
Just in there.
Is that your spot?
Yep, exactly. Yep.
Just go back to there again. Are you feeling it yet?
No.
Or you need me to add that little bit to it. Okay, up you come. Now let's see you turn to your right. You feeling anything?
No. Oh, yeah, that brings it on a bit.
Now if I take you further,
No, it's just in the neck.
just the same spot.
Same spot.
Come round again. It's still just in your neck.
It's funny, it goes sort of...
In rhythm with what I was doing.
Yeah, that's right.
What happens if I...
Oh, that hurts.
Where? Same place?
Actually, it is the same place, but it's a little bit down further too.
Down where?
Down
Touch.
in there.
And that's where you do get your pain sometimes when this is bad.
That's right.
Is that right?
Exactly the
Same
same one.
All right. Can you lie down on your tummy for me again? I could find very readily swelling, thickening, stiffness round about the C3 level, sort of C3 to C5. How does that compare there with if I do the same thing Down there.
Actually, the second one's worse.
There?
Mm.
Should I go higher or lower?
No, that's nearly the same pain as I get.
Where? In your neck or down in your
No, just in the
supraspinous
neck.
fossa? In the neck.
Just in the neck.
And if I press harder, is it still just in your neck?
Yep.
How does that side compare with that side?
Well, that just feels like your thumbs.
But the other side doesn't feel like my thumbs.
No.
And what about that?
Yeah, that's a bit sore. It's not quite the same pain though.
Is it superficial or deep?
No, it's deep.
How deep?
Mm.
Millimetres or inches?
Or half an inch.
That's fairly deep. Okay. So what I'm going to do is to provoke that discomfort that you get in your neck, and then we'll see what it does. Am I on it?
Yep.
Is that deep?
Very deep.
What about there?
Oh, that even hurts a bit in my shoulder.
Thank you. All right?
Yep.
You still getting it in your shoulder?
There I am, yep.
There. But if I come down there, you get just your neck.
That's right.
When I'm up now here, that's C5, and that's neck, and that, which is down on C6. That going out to your shoulder again, in that same sort of area.
That one there.
There. A fine difference between the two. There and there. They wouldn't be more than 1.5 millimetres apart. Okay. How does that feel when I do that?
Looks nice.
You can feel it doing you good, can you?
I hope so.
Okay, well, let's have a look and see. Just sit up again on the end. Just wriggle your neck around to loosen it off a bit. Okay, how does that feel now compared with when you were sitting up a minute ago?
Feels different.
In what way?
I know it's sort of sore.
Is it my thumbs or is it your problem that's more sore?
It's definitely not my pain. I think it just feels like your thumbs have been boring in.
They have been. Can you just try it? We'll do it in the same order. Tip backwards again. Feeling anything?
No.
Come on, back you come. Come on. Still nothing?
No.
Right, now we'll see whether... You tell me when you start to get it.
No, that's fine.
All right. That's nice, isn't
That's
it?
better, isn't it?
Turn round to your right. Anything?
No.
Just sit your head up. That's right. How's that?
No. Yeah, it's sort of just normal stretch, isn't it?
Where was the stretch?
Over here, somewhere.
Turn to your left.
It's the same thing over there.
Right. Turn round to your right again. I can tip your head back this time. Let it come. Round again. No. Just let it turn. That's the boy. Nothing?
No. That hurts.
Where?
In the neck.
Just in your neck?
Yeah.
Can you bear me to do it once more?
Yeah.
Right. So I'm going to use going to use my thumbs partially to change the thickening of soft tissue, and secondly to increase that range of movement in there. And I'm not going to be terribly fussy about which level I'm doing it on, except that I'm not going to do it on CT or T8. And I'm also going to push him down in that direction. And then we'll make it a bit more comfortable. Right, sitting up again.
Were you pushing his hard?
Harder.
That's funny.
Right.
It didn't
Funny
hurt as much.
ha-ha or funny peculiar?
Funny peculiar, didn't hurt as much.
Right, backwards. Come on. Okay.
Fine.
Let someone do that once more. Can you do it again? Just let your mouth come open. Right open. That's right. Now, if I get you right down there,
No, it's still fine.
turning to your right. Spin. Come on. Nothing?
Look. That's still a bit.
About the same as last time,
No, it was not as much as last time.
wasn't it? Well, I think that's enough. If I do any more than that, you won't be able to tell what's soreness from me and what's your problem. And can you take notice of anything that happens? If you think you might forget, write it down. You're not making yourself a hypochondriac. I'm interested in 0.5%. You can't tell me too much. You can tell me too little, so that you're responsible for part of the treatment. Okay?
Okay.
Good. Might stir you up a bit, but take notice and let's know. Well, Chris, how are you? How's it been?
It's about the same.
The same as what?
Or about the same.
That's a good example of not assuming things. Sorry.
Just the same as it was about a week ago.
And I've seen you twice since that week ago. Is that right? What is it that is the same or seems to be the same
It's only that bit.
in your neck? What about this that you had down here in the beginning?
No, that's been fine.
Has it? And that right-sided spot in your neck, does that feel any different in character or anything like that, or is it just the same as it was 2 or 3 treatments ago?
No, it just feels about the same. It might be a bit less.
Can you tell the difference between my thumb's soreness and your neck disorder soreness? And is it my thumbs?
No, I think it's still it.
The thing. So that if I were to push you around and things, you feel that you'd get the same response.
That's right.
All right, up until those last 2 treatments, do you reckon you were improving then?
I seemed to be improving up till then. And then I was a little bit worse after one of them. And then it's been the same since.
When it was worse, do you know what made it worse?
No, just wasn't as good that day.
Thinking back to when we first started, are there any things that I did at any stage which seemed to help you more than other things? Going through the stage when you were showing progress and we changed around doing different techniques, was there any one particular thing that stands out in your mind?
Well, the traction seemed to be helping until that last one.
What happened with the last one?
It was worse after that.
Which was worse? What part?
That part there, my neck.
And that was when then? What day was that?
That would have been that last traction treatment.
The last one? And did it stir up that spot in your neck while it was being done, or was it afterwards that you noticed it?
It seemed to be just in the last 2 minutes of it. Or it seemed like 2 minutes.
And did it pick up after that when we stopped doing the traction?
Yeah, it was sore for a while, and then it came back to the same.
The same level. So you, even though it stirred you up, and when that recovered, you hadn't gained from it.
That's right.
Do you feel, or does your neck tell you that as you have plateaued at this stage, that it may be that the traction would have helped or could help even now if we were to do it gentler and for not as long, shorter period?
It's funny you said that, because I thought about that last night, and it seemed those first two were really good, really helped that a lot. It seemed to be improving day by day, and then that last one, it seemed to be longer and actually seemed quite a lot stronger than the one before.
Did it?
And that seemed to make it worse.
Right. So, what would you think about doing the traction again, doing it gentler, and for a shorter period, and do that for a couple of times and see how we go with that? Does that make sense to you?
That's what I was hoping you'd say.
Good. Okay, let's do that. Well, Chris, we had a 2-week break. Have you been?
Much better, thanks, Geoff.
Much better than what?
Much better than the last time I was here.
You mean much better than after the last lot of traction a fortnight ago?
Yeah, it's got better.
With those 3 sessions of traction, looking back on that now, they were gentler and they were shorter time. Do you feel that each of them helped you?
Yes, everyone helped.
So how did you feel the last time when you walked out of here in comparison with when you walked in here on that one treatment session?
I felt better straight after the treatment.
All right, so now we've had a break of 2 weeks. What's happened during that 2 weeks to those neck symptoms? Because this is all you had left, wasn't it? This had gone.
Just that.
Right?
No, it's just continued to improve.
Now, when you say it's continued to improve, we stopped on a Friday, and do you mean that Saturday was better than Friday, Sunday was better than Saturday, Monday was better than Sunday, and that you had that sort of day-by-day improvement?
It seemed to be that Saturday was the best day, and then it continued to improve, but not quite as much as that Saturday. So it improved that much on Saturday, and then that much Sunday, that much Monday. But each of those days afterwards improved a little bit at a time. And
about the same amount. So does that sound to you as though it's making some sort of spontaneous recovery of its own accord?
Every day seems better.
All right. Do you think that it is improving sufficiently for us to be able to say, well, go away and let's see you in 2, 3, 4 weeks' time?
Definitely.
All right, and you've got the option that if things don't continue to improve of their own accord, give us a ring, come in, and we'll decide what we'll do.
Thanks a lot.
Make sense? Good. Just lying there at the moment, can you feel any discomfort in your shoulder?
It's aching.
Just unlink your fingers, that's it. Just let your arm relax and let me move it. How does it feel there?
That's better.
Can I make it more better?
I think if we'd moved that a little bit, it might.
Which way?
Outwards. Yeah, that's better.
Is it? What if I come up there?
No.
It's better down about there and there. Okay, just let your arm rest down again. Don't you lift. It's not high enough, is it?
No, it's not quite enough.
How's that?
That's good.
Can you just hold your hand there with your other hand? How's that?
Feels lovely.
Can I improve on it?
No, that's the best it's felt in ages.
Good. Still feel all right?
Yep.
How's that?
It's just a little bit.
A little bit of what?
The ache.
Still there?
No, not now.
How about that?
No, that's better.
You feeling anything?
Just a touch. That's better now.
Is it in what you could feel? Was it in rhythm with what I was doing?
I can't remember.
Righto. So I'll go a bit further.
Well,
Now,
that is, yeah.
right, now if I keep going at that same rhythm and same position, does it get worse or does it just stay the same?
Just the same.
Okay. So I don't want you to feel anything at all. Not for this first time. All right so far?
Yep.
And how about that?
It's fine.
Nothing.
Nothing.
You tell me if you feel anything at all.
Oh, it feels nice.
I'm going to try and sneak in a bit further, but I don't want you to feel anything. How about that?
No, that's good. That's a bit sore.
Right. All right now?
Yep.
So you can tolerate that, can you? Is that the same nice feeling?
Yep.
Okay. Just going on for about another 10 seconds. Still all right?
Yep.
Okay. Let me hold your arm. How does that feel in your shoulder now compared with before I put the pillows all around?
That ache's not there. That's still good.
Good. Okay. Can you just rest there for a while before you come out?
Okay.
Because I don't want you to start moving your arm around for 10 minutes.
Okay.
And then just come out. Good. Thanks. You feeling anything in your shoulder now?
No.
Nothing. And if I do that, that's all right?
Yep.
Nothing.
Nothing.
Okay. So if I now push in there and then just move that like that, you getting anything with that?
Not much.
So if I do it up there.
That's more like it.
When you say that's more like it, do you mean that that resembles in any way what you feel when you're playing a full hand?
That's the same pain. In fact, it's getting a bit worse.
Oh, good show. That's just what we want.
That's just like it.
Good.